Um, Good evening, everyone. Welcome to the educational webinar series organized by Iraqi Stroke Network. All webinars are endorsed by MENA Stroke Organization, and today we open our 12th webinar. I would like to welcome our speaker, Dr. Nour, and all of our attendees. My name is Israa Ali, and I am neurologist at the Diwaniyah Teaching Hospital. Now I leave the word to our panelist, Dr. Mohammed Kurmanji, Assistant Professor of Neurology at Sulaimaniya University College of Medicine, and fellow neurovascular interventionalist. The word is yours, Dr. Mohammed.
السلام عليكم جميعا.
عليكم السلام.
It is my pleasure again to be a panelist in this regular scientific activity, and our welcome to Dr. Nour will share us with the up-to-date advance in stroke management, including mobile stroke unit. عودتنا العراقي ستروك نتورك to attend this regular scientific process and learning and lectures, and we are with the Iraqi Stroke Committee. We can all together work together to raise and to upgrade the stroke management in our country. We hope that although we start late, but I think there is a time for maybe short time for us, long time for our junior doctors to start with advanced stroke management. Really, after the great achievement in stroke management in Iraq, after the establishment and authorization of the stroke program in the last months by our kind and great work of the consultant stroke committee in Iraq, we are happy again to hear and to raise this achievement to include again in the future mobile stroke unit. But we have again before the lecture, we want to have few points we want to concentrate with them. One of these points that they said this mobile stroke unit is variable in size. We should know the availability, how it is to make it available and to make it work easily in our locality. We have different situation and logistic issues and different from other sites and other countries in the world. So we want in this lecture to take all the issues, including logistic issues mainly, and again the same mobile stroke unit, how is large, how it's easily to work, how can transfer the patient easily to the hospital, is need time to work, is the need time to establish the patient and to pick up the patient to the hospital. We want also to discuss about how much will help us regarding management of the patient. And I think, inshallah, this will be discussed in your lecture, especially that we have a few centers. I think one of this main center which want to arrange for this is Najaf Center. They want to arrange for mobile stroke unit in the future, and they want to have all the information about this mobile center that help to manage the patient as early as possible with less logistic and less obstacle issues. And thank you so much to introduce me again, and we introduce Dr. Nour, which inshallah help us in these issues and enjoy us with her lecture.
I'm going to lead this webinar tonight along with Dr. Ibraheem, who will lead the Q&A section. Dr. Ibraheem, if you want to introduce yourself, please.
Thank you, Dr. Israa. My name is Ibraheem. I'm a student at the Iraqi Board for Medical Specialty at the Najaf Neurology Center, and I will be happy to receive your question in the chat box so we'll discuss with Dr. Noor at the end of her lecture. Thank you.
Thank you, Dr. Ibrahim. And in the name of Iraqi Stroke Network team, we are privileged to have Dr. Nour, MD, PhD. Dr. Nour is a health science clinical assistant professor in the Department of Neurology, University of California, Los Angeles, Comprehensive Stroke Unit, and she is a director of Erlen and Henrik Lok Mobile Stroke Rescue Program, and also in the Department of Radiology as an interventional neuroradiologist. Dr. Nour has her doctorate of medicine from University of Arizona, Phoenix, and she holds the degree of American Board of Neurology and Psychiatry and the Medical Board of California. She have an interventional neuroradiology fellowship in Los Angeles, California, and vascular neurology fellowship also in Los Angeles, California, US. Dr. Nour, thank you for sharing this lecture with us, and please you can proceed.
Thank you so much. أول حاجة السلام عليكم. أنا بجد مبسوطة قوي إن أبقى معاكم I will switch to English for the rest of the talk, but you brought up some excellent points about regionality and systems of care being very local, and I am more than delighted to kind of share ideas with you about how to go through that. But what I'll share with you is mobile stroke unit experience in general, and then our particular local experience in the county of Los Angeles. So it's my pleasure to be here with you today to talk about revolutionizing the landscape of pre-hospital stroke care. Stroke care, or actually emergent care for patients, existed a long time ago, starting at 1837, where the patenting of the first ambulance, basically with a gurney on the back of a horse, and the first ambulance with a stretcher was patented in 1889. The first ambulance with imaging was actually the Les Petites Curies in 1914, which were the first X-ray equipped ambulances that happened in the World War, where wounded soldiers were being scanned in the field. And now we see a trend towards increase in specialization of EMS resources. In our county in particular, for example, there are nurse practitioner response units for de-escalation of care, meaning that if someone doesn't need to go crowd the hospital, and maybe they have a slightly high blood pressure or slightly hypotensive, etc., the nurse practitioners can go administer IV medications, make an appointment with the primary physician of the patient, and then not have to transport the patient to crowd the hospital system. Another de-escalation of care unit that's specialized within our fire departments are mobile community homelessness response units. And unfortunately, we see in California a great and tremendous epidemic almost of homelessness, perhaps because of the climate, the very nice climate we have here. Then many of the homeless in California have transported towards Santa Monica and other areas in Los Angeles. And the problem is a lot in terms of mental illness, housing, and so forth. So these mobile homelessness response units help with not only medical but social services for these patients. And oddly, also enough, alcohol abuse is high in our community, and there are emergency sobriety response units, so someone doesn't have to go detox or sober up in the hospitals, taking up a bed of a patient who needs more critical care. There are fire department EMS sobriety response units. And these are all examples of de-escalation of care. And now for the examples of escalation of care, for example, mobile ECMO units, which are designed to put patients on ECMO and transport them to higher levels of care. And although our mobile ECMO unit is a critical care transport unit, does not respond to 911 or emergency medicine calls, others in Europe, for example, have shown this escalation of care, canalizing patients on the streets of the subway and in the Louvre. bringing us to the topic of what we have to discuss today, or escalation of care in stroke. Mobile stroke units. The UCLA Health Mobile Stroke Unit began as a public-public partnership between the University of California, the Los Angeles County Board of Supervisors in 2017. We started this program and participated in one of the two pivotal trials or landmark trials that showed clinical benefits of mobile stroke units in ischemic stroke care, called the BEST MSU, where there were 7 U.S. cities participated. This was a prospective, multi-center controlled trial of mobile stroke units, and it basically assessed the outcomes or clinical outcomes of patients who were treated earlier with IV thrombolysis on mobile stroke units compared to patients, the same type of patient treated later in the emergency department. Be Proud was the study out of Berlin, and taken together, both studies showed significant benefit, as we can imagine, because of time savings to patients who were treated sooner in mobile stroke units with IV thrombolytics. To give you an idea about the magnitude of benefit, the number needed to treat out of 100 patients treated earlier in mobile stroke units with clot-busting medications rather than later in the emergency department, 27 were found to have a less final disability, including 11 of whom who became disability-free. And this is very significant. But one may then ask, what about the cost? And not only did we show that there is clinical benefit, but there's also certainly cost effectiveness of these units. And this was what was presented at the International Stroke Conference a couple of years ago for the BEST MSU trial. This patient is actually, this paper is actually accepted for publication and will be in press within the next month. But ICER, or incremental cost effectiveness ratio, is one measure in which we measure how cost effective a medical treatment is. In the United States, anything under 65,000 is cost effective, and in the MSUs were found to be 33,537 per quality adjusted life year. And as you can see here, anything under 63,000 is highly cost effective, and of which this treatment qualified. Berlin study, also the Be Proud study, looked at their ICER and their economic evaluation, and per quali, for something to be effective in their environment, needed to be between 40,000 and 80,000, and it fell right at 40,000. So again, another highly cost-effective proof within an area outside of the United States. So what can mobile stroke units do? I think one really, really essential thing I want to put across here, these are not just treatment units, but these units benefit patients greatly in conclusive pre-hospital diagnosis and triage of the patients to the most appropriate level of care. Our clinical operations, each mobile stroke unit around the world has maybe a different set of clinical operations, but our clinical team is composed of a vascular neurologist, either in person or by telemedicine. In our mobile stroke unit, there are 4 primary vascular neurologists who cover. 2 of us are interventionalists and 2 of us are vascular neurologists. There's a firefighter paramedic, a critical care nurse, and a CT technologist. We have the laboratory capability to get a Chem 8+ and a coagu check, and the imaging capability to image not only the parenchyma or tissue of the brain, but also the blood vessels of the brain with CT angiography. We've attempted to do CT perfusion only for 2 patients within our unit, because with this limited 8 and 16 slice scanners that are currently available, you only get 1 slice through the brain for the perfusion. So it's really not, it's not worth the contrast given. So in terms of treatment capabilities, we carry not only alteplase, but also tenecteplase, as many of the hospital systems within our region have switched to using from alteplase to tenecteplase. That's for ischemic stroke. For hemorrhagic stroke, we carry Kcentra. We hope to carry andexanet and other hemorrhage reversal agents like Praxabine. And we carry not only Cardine, but also other blood pressure controlling medications. And in addition to that, to treat other neurologic emergencies, we carry, of course, IV fluids, antiplatelets, anti-epileptics, antiemetics, and ACLS meds, and meds for anaphylaxis. So how does our mobile stroke unit interact with patients? We are actually tied and within the part and parcel of the emergency medical system for our county. So we are listening on the radio to the fire department radios who are dispatched to the primary calls. And let me give you an example of that, of how when we attach to a call, we hear that there's a call suspicious for stroke, we attach the mobile stroke unit, the crew immediately dispatches, and we arrive on scene. So hopefully you can see my screen. Can you see my video? Hopefully you can
Yes,
see my video.
it's clear.
So this is us arriving on scene with the fire department to evaluate a patient. And Los Angeles County is unique in that the fire department with the fire engines are actually responding to the EMS calls. There are paramedics cross-trained of the firefighters, and that's who responds to medical calls within our county. So sometimes the physician is either there in person or by telemedicine, and so there are many ways that you can facilitate having a better telemedicine interaction, not only inside of the unit, but also outside when you're going to evaluate the patient. And this is one such hands-free solution. So now to show you us going into the scene, you can see that multiple fire departments, rigs, both ambulances and the fire engine. And we're going here particularly into a skilled nursing facility who was called because of an altered patient. So if we assess the patient together, many times the dispatcher impression is not correct. And so we may get canceled en route before we arrive because the paramedics don't think it's a stroke. We may arrive on scene and say, we agree, we think it's a stroke, but this is 1 week old. We should only take patients within 24-hour time window, last known well time, and with focal neurologic deficits that look like stroke. And or alternatively, we think this is a stroke, this is for us, and we end up taking the patient, and the primary EMS service can go back to their service and availability to take another call. We assume the care for that patient, and after we do so, here are some images from the field. You can see a very seamless interaction between us and the fire department services, and you can see that there's great interest on the behalf of the paramedics, the firefighters, to understand what's happening with the patient, when it's happening, how it's happening, and how they can benefit this patient. And this is something that I really didn't realize how important and essential this is, but there was so much learning on my part, not having been in the field before, of how hyper acutely patients can change and deteriorate, and how uncontrollable this environment is. It's not like the controlled environment in a hospital system. So you really have to be very adaptable and very creative on how you do things. And that we have a lot to learn from the medics, and they have a lot to learn from us. So even having that immediate same moment feedback about what this patient is it really a stroke? Was it a hemorrhage or ischemia? Seeing us give medications has been really tremendous education for our county system paramedics. And so you can see here a lot of great interaction with our medics. And we've only had to intubate one patient since the essence of the program. This was a patient who had was dispatched as a seizure when we arrived on scene, had obviously seized, had vomiting, first time seizure, had not been known to have a seizure disorder. We admitted the patient to rule out hemorrhage or other. And in fact, the patient had a fulminant, unfortunately, bilateral subdurals, and we had to intubate that patient en route. These are examples of our laboratory equipment that we can get in the field. And once we admit the patient, have a clear understanding of the clinical scenario, have the imaging, get the CT scan, the CTA, get vascular access, get laboratory testing, then we can make a diagnosis-specific treatment plan and initiate treatment for that patient. After we initiate treatment, we then transport the patient in accordance with our LA County EMS guidelines to the nearest stroke center of care. Although this is operated by UCLA Health, this is actually a community resource for our entire county. So to kind of give you a relative understanding of time saving, these are MSU treatment times relative to the average in Los Angeles County if transported by a regular ambulance system. So looking at last known well to thrombolysis, these are median times. And in LA County EMS, regular transport, the median time once patient arrives to the hospital, last known well to IV thrombolysis of 107 minutes, whereas the mobile stroke unit saves 40 minutes with 67 minutes, last known well to IV thrombolysis. In terms of first medical contact, meaning that paramedics arriving on scene to IV thrombolysis or mobile stroke unit arriving on scene to IV thrombolysis, Our average was 32 minutes from first seeing the patient, and an average for a patient transported directly to the hospital would be about 61 minutes, even in best possible case scenario. So you can see that there's a 30 to 40 minute time saving. And of course, as we know, time lost is brain loss. And the triage decision, I think, is also really critical. It's also really critical for us to reframe our mind about these units. They're not only IV thrombolysis units. These units can serve a much greater good for all patients with neurologic emergencies in the field and be applicable to many types of patients. And this is a publication by Dr. Fassbender that's showing pre-hospital management optimized either by pre-hospital severity scoring LAMS. LA Motor Scale is a scale that's used by paramedics in our system to triage patients for severity of stroke scale. LA Motor Scale consists of 5 points. 1 point is given for a facial droop. 1 point is given for weak grip. 2 points are given for no grip. 1 point is given for arm drift, and 2 points are given for no arm movement at all. So a LAM score of 4 or 5 had a sensitivity and specificity for predicting large vessel occlusion of about 88%. So it's not 100%. And in this paper, whereas they triaged patients with LAMs with an accurate decision of about 70% in using LAMs, using mobile stroke management, understandably so, with experts there in the field with the patient, gave a triage decision accuracy of 100%. So I really think this is a great and really important role of MSUs. The other important role of MSUs, and as an interventionalist that's near and dear to my heart, is that MSUs can expedite not only pre-hospital, but also in-hospital care. So you can imagine by doing the CT angiogram in the field, already having a family member contact, transferring these images early in time, you can achieve a much better preparation of your angio suite and much better achieving in door to puncture times and IV and recanalization, intraarterial recanalization. We use different imaging servers and apps and tools to help us expedite care. And for example, if I'm on clinical service in the hospital, I may be covering by telemedicine. And by having kind of this idea of packs in my pocket, as I'm rounding on inpatients, I can immediately see what's happening with the MSU patients on an app in my pocket that reconstructs the CTA, but also you can see the CTA source images. That's one app that can be used. That's the one we use, but there are, of course, many more apps. So this is an example of a CT angiogram, APN lateral reconstruction from the Rapid app for one of our MSU patients. And you can see that this is just a screen sharing from my phone, that you can be able to also appreciate the source images. And for an 8-slice scanner, this is pretty decent quality that you can at least see if there's a basilar occlusion, an ICA occlusion, an M1, an M2 occlusion, and maybe kind of perisylvian fissure. Maybe you can see pruning of vessels or decrease in arborage, but that's as far out as you can see. But so now, to give you an example of a case, this is a 46-year-old patient with acute onset of aphasia, dysarthria, right facial droop, right arm more than leg weakness. You can see on the non-contrast CT, even before doing the CTA, the hyperdense sign in the sylvian fissure that you can see with the yellow arrow. Then you can see on the CTA reconstruction coronal view that there's proximal M2 occlusion in this patient, or M1, M2 bifurcation occlusion. And that is interpreted very well also in the images by Rapid. This patient had a LAM score of 3. In our county, any patient with a LAM score of 4 or 5 is routed directly to a comprehensive stroke center, bypassing primary centers in order to have access to thrombectomy. But this patient would not have been rerouted based on their LAM score. It would go to the next primary stroke center. And you can imagine the delays it would take after identifying an LVO to transfer the patient, and the outcome would be really deleterious. And because this patient had cortical signs of aphasia, we accepted the patient to our unit, and we thought this is what we would see. And pre-notifying the hospital, first of all, we gave IV thrombolysis within 62 minutes of last known well for this patient on the MSU. The imaging showed a left ICA dissection with a complete occlusion of the left ICA. And by the time they had arrived at the hospital, the patient had recanalized the M2 because of the IV TPA and did not need intervention. And the door to puncture time, imagine our goals are less than 60 minutes. And in this patient, because of the pre-notification, this patient was able to achieve less than 15 minutes door to puncture time, which is remarkable. And in another case, this is an 84-year-old woman, with vascular risk, with unknown vascular risk factors, who presented with a transient right hemiplegia, which resolved on our presentation. Her NIH stroke scale was 8. She was aphasic and she had a gaze preference. She did not have any motor findings. And because LAM score only looks at motor findings, her LAM score was 0. So again, the paramedics would not intuitively route this patient to a higher level of care or comprehensive stroke center. But because of the cortical sign, we said, we're going to admit this patient. This must be an LVO. So, sorry, here we go. You can see some images from that run. So this is just right outside of the home of the patient. And a tremendous collaboration again with the medics. And you could see that not only did this patient have another M2 occlusion, but then she was able to be delivered to higher level of care for thrombectomy. And this is her thrombectomy procedure with a stent combined aspiration approach. And here's the pre-thrombectomy CTA and the post-thrombectomy CTA with the clot and with an MSU door to IV thrombolysis time of 13 minutes, a last known well to IV thrombolysis of 62 minutes, and a door to puncture time of 24 minutes. So tremendous time savings. But not only can we help for large vessel occlusion, ischemic stroke, I think mobile stroke units are really exquisitely poised to help hemorrhagic stroke patients as well, not only in identifying the hemorrhage very swiftly in the pre-hospital setting, but in early initiation of reversal of anticoagulation, early initiation of antihypertensive, and in giving prophylactic anti-epileptics. This is an example of such patient. This patient was a patient who was 78 years old. He had vascular risk factors of hypertension on aspirin. This patient, the paramedics were really confused about what to do with this patient because unlike of their teaching of LAMS, which evaluates face strength and arm strength and you know, strength in the fist, this patient only had isolated lower extremity weakness. He was trying to climb into his car. He was unable to lift his leg to get into the car. And because of that, they were even uncertain if the patient even had a stroke. But to them, they couldn't understand that there's an isolated leg weakness can be presentation of stroke. We admitted to the patient to our unit because of this acute focal neurologic change. And you can see here from the CTA that you can appreciate a hemorrhage in the ACA territory. And so because of that, the patient, because of this conclusive diagnosis, the patient was able to have hyperacute initiation of antihypertensives. He was loaded with antiepileptics, and he was rerouted from a primary stroke center to a comprehensive stroke center based on imaging. So all systems are local, and happy to talk about your system and how this can dovetail into it. But in our system, we wanted to understand in this very large metropolitan area how we can apply mobile stroke unit systems and deploy them in a large metropolitan region. So we wanted to look at evidence-based geospatial mapping to identify the positioning and number of mobile stroke units needed in our county using regional stroke heat maps of 3 years worth of data to look at basically patients who had after transport then final hospital diagnosis of stroke, including all of the diagnoses listed here. We started with about 12,000 records, and at the end we analyzed, because of data availability, over 10,000 of those. And like we said, all regions are local, and so this is Los Angeles County. And one unique thing about Los Angeles County is its breadth. You can see it surrounded here by Ventura County, Kern County, San Bernardino, and Orange County. And this is one of the U.S.'s largest counties, all over 4,000 square miles, a population of greater than 10 million residents, and 27% of California's population is in this very tiny red dot, which is the Los Angeles County. And almost $40 billion in budget, approximately a third of that is dedicated to health services. So we wanted to look at the geospatial mapping heat maps. And so again, this is representing Los Angeles County. Anything you see in dark shades is higher incidence of stroke. and you see in light shades is lower incidence of stroke. So you can see that there are, in particular in San Fernando Valley, St. Gabriel Valley, in and around Inglewood, there are areas of particularly high incidence of stroke. And when we look at ischemic versus hemorrhagic stroke, you can see that although the pattern is quite similar, again, San Fernando here and here, a little bit in St. Gabriel, a little bit more here, that you can see that some areas are not congruent. For example, here down in Palos Verdes, you can see high signal for ischemic stroke, but not a high signal for hemorrhagic stroke. So there are certainly some differences based on the population in these regions. We wanted to understand if daytime versus nighttime strokes mattered, how long do we need to staff these units throughout the day. So this is looking at Monday through Friday versus Saturday, Sunday. No big difference. The majority of strokes, over 71% of them, happened to be called in between 7 a.m. and 7 p.m. with a smaller amount between 7 p.m. and 7 a.m. This is the day and night distribution on that geospatial map. And here, each individual blue dot is an individual 911 or EMS call that resulted in a final hospital diagnosis of stroke. And each red dot is one of the locations of the stroke centers, whether primary, thrombectomy capable, or comprehensive. And we asked the algorithm to put in for us within a 10 to 12 mile radius the location of as many mobile stroke units as are needed to blanket this county. And because of these geographically disparate areas, we asked it to enter force two more to deal with those areas. And with 5 mobile stroke units in our county, we have the potential to cover about 87% of all 911 calls dispatched who resulted in a final hospital diagnosis of stroke, with about 13% uncovered. And with 7 units, potentially we have the potential to cover almost 92% of these patients. Of course, access to care changes with traffic patterns, especially in a city like Los Angeles, where traffic is absolutely horrendous. And sometimes you can only get 1 mile in 20 minutes versus 10 miles. And so based on this, we also made accounts for weekday morning rush and weekend and late evenings and so forth. So this is to give you an example. I wanted this mostly to be an introductory meeting to this topic and give enough time for Q&A and try to be helpful in how you can apply this to your system of care. So I'll pause here, and I think a discussion will be really beneficial. Thank you very much.
Thank you very much.
Thank you. Dr. Ibrahim, do you receive any questions?
Yes, thank you, Dr. Israa. I have a question for Dr. Nour. First of all, thank you for this nice lecture. I have a question from Dr. Khalid Ambar. It's asked about the complexity of the process to activate the mobile stroke unit. How much time do we need to operate the CT scan, and the time needed to reach to the patient? And also, he asked about the availability of the mobile stroke unit. Is it easy accessible?
Question. Yeah, great question. So I think the success of it becomes if you become part of your emergency medical systems of care. So this would have to do with how you dispatch for patients and the accuracy of the dispatch. One major challenge all over the world for mobile stroke units, including in Los Angeles, is the accuracy of dispatch. So somebody calls for this type of emergency response, and they may say, my grandma is weak and she fell out of bed, and that may be dispatched as a stroke call. And to give another example, the same person may call and say, my grandma fell out of bed and now she's weak, and that becomes dispatched as a trauma call. So when the mobile stroke team is screening these calls, you may not get to the right patient because it was inaccurately dispatched. So that's something we really have to work on, and we have to examine at the level of your operating system. How accurate is dispatch? Can we get to the patients? And then the other challenge, I'm just going to give you an example. Being in Egypt, just recently for the Minasino conference, and just when we visit in the summer, I see ambulances with sirens all the time. Nobody moves out of the way. How do you get a patient to the hospital? And here in Los Angeles County, it's very different. There are very big rules about ambulances driving code and where you park and how you clear the way for those patients. And so we're very fortunate that we can get to the patients very fast and on time, but we have to understand what to do in different systems of care. But I should argue that potentially that's even more benefit for the patient, because the patient is stuck in traffic, not ever getting to the hospital on time. They may miss an IV thrombolysis time window. So how wonderful that you brought this hospital on wheels, primary stroke center on wheels, and helped treat the patient before they were not eligible for treatment. So I think the logistics of this, for us, the logistics of dispatch are very easy. We are carrying the radios of the fire departments. We are listening. Anything that sounds like it's a stroke or that sounds like it could be a stroke, syncope, seizure, altered consciousness, severe headache, we attach automatically to that call. We get in the rig and start driving to them. And we arrive on scene with the 911 response, and we evaluate the patient together. And if this is a patient who's suitable for admission, we'll take them. If the patient is not suitable for admission, they'll take them. And no problem, we're released to our next call. So I think what has to be taken into account are how the environment is, how do you operate, and funding has a lot to do with how long you can afford to operate. Can you afford to operate 24/7? Is having personnel available all that time is expensive or not? In Los Angeles County is very expensive. Paramedic salaries and nurse salaries and so forth. And so currently we're operating 7 a.m. to 7 p.m. 6 days a week, and we take one rest day, which is Sunday, because the ambulance itself with the diesel engine had a lot of mechanical issues when we were operating it 7 days a week. All mobile stroke units currently in the world, and including ours, are operating right now based on special project funds and philanthropic funds from donors, because there's not a system of care of our insurance, Medicare, to recognize the place of service. Basically, we can bill for activities we do in a hospital. We can bill for them on an ambulance. We can bill for them in an imaging center. But there does not exist a place of service that combines a hospital, an imaging center, and a transport ambulance. And that is the thing that we are lobbying for and working with on the national level with Medicare to be able to get reimbursement, because then we can sustain funding for these, and we can operate 24/7, and we can have many of them. And although we have only currently one mobile stroke unit in Los Angeles County, we alternate every 3 days in a different region. Then, thankfully, we were able to get very kind donors who gave us funding for 2 additional ones. So the first one will be added in next February, and the third one will be added in March or April.
Okay, thank you, Dr. May. I'm sorry, but just Dr. Mohammed Kurmanji, please, if you have any comment on Dr. Nour lecture, please come. Dr.
Thank
Mohammed.
you, Dr. Nour, for this nice lecture. I want to know from you that is all the mobile stroke unit available with only native CT or CT NGO also? This is the first question. The second question, that when you have a patient transferred or admitted, they call you, sorry, and the mobile stroke unit take this patient. There is how many doctors usually inside the mobile stroke unit? How many nurses in addition to the driver? And what is the first things they are doing? We need to have more information about these steps. I mean, they doing an IHSS or LAMS score, and then they assess the patient regarding the rapid investigation, and then they're doing CT, and then they have telemedicine, or the doctor will be available. Then when they're reaching the hospital, the nearest hospital with stroke unit, whether primary stroke center or secondary or tertiary, is it easy that to transfer the patient from this mobile stroke unit to the triage or to the cath suites, or sometimes there is some difficulties? Is the car or the truck is a small size or should be larger? Is it easily to pick up and to take off the patient? This is the question that we should know about it more than other things, because you know that our logistic and
Yes.
our situation is different from other countries. And we
Mhm,
have a crowded traffic in most of our cities. Okay, thank you.
Of course, excellent questions. The first question with regards to the availability of the types of CT scanners. Currently only 3 CT scanners, potential CT scanners exist that you have options to. One is Samsung Neurologica makes an 8-slice CT scanner. That's the one we have currently. That's the first generation of the CT scanner. Then Samsung Neurologica made a second generation of that called the 16-slice scanner. And I personally have not heard good things about that second generation scanner, a lot of technical problems and a lot of repairs and so forth. And then, so you have 2 options in Samsung Neurologica. You have 1 option in Siemens scanner, actually had just received FDA approval within the last month. And then we will be the first, inshallah, in the world to have the first 32-slice Siemens portable scanner in a mobile stroke unit for this one coming up in February. I think looking at the quality of the imaging of the Siemens 32-slice scanner is going to make a huge, huge difference for me personally. The next question with regards to the exact specifics, the unit there's no specific, I should rephrase that. There are some specific dimensions in which the unit should be in order for safety rating, God forbid, for crash testing of the scanner and so forth. And there are 2 companies who primarily make these mobile stroke units in the United States. And the one I really highly recommend is called Fraser out of Houston, Texas. They make probably 90% of the mobile stroke units who exist now in the United States, and including the one in Saudi. They just delivered that one. They have done extensive crash testing, and I really appreciate that so much. And also they have done extensive kind of electrical testing and so forth, because of the CT scanner, this unit needs to be either idling, meaning like the engine turned on the whole time, the whole day, or plugged into specific shoreline power. Because the CT scanner cannot be turned on and off and on and off, you need to either have the engine on or this thing is plugged in. So you want to put this in an area where it's easy to dispatch. When it's plugged in, the staff have somewhere to sit. It's close to where the strokes are occurring. It's close to what's it called? Like you have the meds, everything. And our specific program, the physician does not have to go in person. I personally go at the beginning. I used to go in person the entire day, all the day. But now, because of more clinical duties, sometimes I'm on interventional service, sometimes I'm on inpatient stroke service and so forth. Then if I'm doing that, then I go at least half a day, but in the morning I go by telemedicine. So physician is physically most of the time not there. The 3 essential people in our unit are a firefighter paramedic. They operate within their scope of practice. Let's say somebody needed to be intubated. That would be the responsibility of the firefighter paramedic. There's a critical care nurse on the unit, and there's a CT technologist. So at least 3 people. If you can afford to put a 4th person, it's like an EMT. This would be helpful because just for hands, during the run. The other question is about LAMs. When the paramedics arrive, the regular paramedics arrive on scene, they do a LAM score. We also do a LAM score, but we do a quick assessment outside of the unit just because we don't want to waste time for the patient. Immediately when we arrive, understanding what are the vascular risk factors, what is the last known well time, clear last known well time, because that's something that's misinterpreted all the time in the field. And then what meds are they on that we should be aware of? Antiplatelets, anticoagulation. Do we need to reverse something if this turns out to be a hemorrhage? Just thinking ahead. Immediately the patient gets into the unit. Then we do the stroke scale there. We don't want to do the stroke scale delay the paramedics outside. We just get an idea. Okay, this person has focal deficits. Let's get in the rig. We get in the rig. The emergent thing, first thing to do, get the non-con CT. And the non-con CT gives us a path. This is hemorrhage, this is not hemorrhage, and then what are we going to do about it? In the meantime, the doctor's on telemedicine, watching everything, listening, talking with the team. The images begin to be transferred. The doctor, at the meantime, is talking to the family on the phone. Let's say I had a patient last week who was in a rehab center. She just had a spinal fusion. and I had to call the physician, the orthopedic surgeon. Hey, are you okay if I give IV thrombolytic or not? This kind of thing. And then talk to family member and get consent and so forth, while watching the team do some of the activities until the scan is out. The 8-slice scanner, the 16-slice scanner, and the 36-slice scanner are all capable of doing CT angiography. So as long as you have an injection pump, you are able to do the CT angiogram. The thing you have to think about is transferring of the images to the physician over cellular network. These images can get larger and larger, and the physician has to make a real-time decision about what's happening for the patient. So it's great if you get beautiful images in the ambulance, but then you cannot transfer those images to go fast enough because of the low cellular signal, then that becomes a problem. So you have to investigate that part of it, the transfer of the images. And the handoff at the hospital, because we drop off at 15 different stroke centers, and because we have established a relationship with all these stroke centers, before we launched, we have to do training with them. This is what's going to happen. This is what's going to happen. Really, it's simple. If you consider as the patient as almost an interfacility transfer, this is a hospital on wheels. And so we give them everything we did in the unit. We even send them the images ahead of us arriving. We know which hospital. We send the images to their rapid software, and they can assess the patient. And as an interventionalist, let's say this is an interventional case, and there's an LVO, I will actually send the images and call the interventionalist on call at the hospital, because we have their call schedules, and give them the family phone number. And imagine the benefit of that. You prepare the angio suite, you can talk to the family ahead of the patient arriving, and the handoff at the hospital is typically very seamless. You can arrange with each hospital if you can do the direct to angio route. I think that's most beneficial, rather than stopping in the ED if you don't have to. And it's basically a hospital to hospital interaction on what they feel comfortable with and what you will deliver.
A question from Dr. Mustafa. Mobile stroke unit is unexpected to apply in Iraq in the near future. What's your advices to inspire some MSU concept in the regular ambulance?
Yeah, great question. I think one critical thing we can start with, at least to help with triage, would be to put regular telemedicine units inside of the standard ambulances, and have expert neurologist assessment that can help based on the clinical exam, based on, of course, expertise the medics may not have, on understanding the routing of patients, where they should go based on their exam. I think the medics, because they know a little bit about so many fields, and we know a lot about one field, they sometimes don't see subtleties of patterns like mild aphasia. They may not consider that a stroke because the patient is not paralyzed. A patient with a basilar syndrome, they may not recognize because of, they can chalk it up to syncope or whatnot. So I think having a regular telemedicine helps with the triage decision making, but of course, without imaging, you cannot be a treatment unit. So without a CT scanner to get at least imaging, I think it will be very difficult. Now, a lot of other companies are coming up with these helmets for looking at TCDs and EEG and other things. And maybe these helmets one day will be a surrogate for us to say hemorrhage, no hemorrhage. But I think very few of us will be comfortable to do that without seeing imaging right now.
Okay, please speak, Dr. Nour.
Okay. Excuse me if I can speak now.
Yes, Dr. Nour. Please go.
Okay. I'm really apologizing because I'm now in another meeting, but because your meeting is so important, so I participate. I want to thank all of you, all of my colleagues. As you know, I am Dr. Marwan. I'm the head of ED department in the MOH, the Ministry of Health, and the ambulance department is also part of our directorate. طبعا from the beginning we was eager to adapt the stroke protocol, and even we are do some adjustment to the protocol. And the idea, sorry, you can't hear me well?
Yes.
Yeah. And we are discussed the idea of ambulance. We discussed the idea or concept of stroke mobile units, the ambulances, because we are now having some kind of special ambulances. We are have the idea to put some of our ambulances for like a specialized one for providing more advanced services. So we discussed it, I think, maybe 2 weeks ago, about the possibility of adapting stroke ambulances, and it's appealing and accepted, and the decision maker here are when I discuss with them, they are ready to adopt it. So I just want to emphasize on this. But of course, this is not, it's not will happen immediately. We need to discuss with them the equipment list, because also as part of our directorate is all the paramedic and the ambulance driver are parts, they are employees under my directorate. We are responsible for training them. We already trained all of them about BLS, some part of the ATLS. Many of them are eager and are willing to participate also. We are now adapting with the ICRC in a program for the AMT next year for advanced training and legislation to protect them, to put the law that to protect their intervention that they will do in the ambulances. So what I don't want to take a long time, but what I want to tell you or to make to say that the idea and the MOH is accepted, and it's they are eager, but the first steps may take time. So I want مثلا to contact you about the list, the equipment list, what we needed, the guidelines, so that's or at least to start with one unit in each health directorate or in some of the directorate that ambulances specialized for stroke, that does not go to other call, just for the stroke. And we are already doing the training. Maybe part of the training will be about stroke. And also
Dr.
we have.
Marwan, that sounds. Sorry, go ahead.
Sorry, I think I don't want to take this. Is the main idea that I want to transfer to you. And thank you so much, all of you.
Thank you. And I just want to say congratulations on this big step of acceptance, because as with anything new, there are always obstacles, there are always naysayers, but I think now we have clinical benefit evidence and cost effectiveness evidence that we have to, as thought leaders, bring this to our patients, to our patient population. So I think it's huge that you've made that first step, and we're more than happy to help in any way. We've helped many programs to start and establish even outside of the US. And it's really wonderful to see. I'll just say from an international perspective, I didn't know about this, but I heard from a physician visiting from Thailand, visiting UCLA and visiting the dean's office there. And apparently in Thailand, their government has deemed this very health benefit issue. And now they're opening thousands of mobile stroke units. I don't know how. They have funding for thousands of mobile stroke. So we hope we can all reach that, where each one of our patients has access to this really, really tremendous, valuable care that can help them benefit. So if you need help in any way, we're more than happy to help.
Thank you so much. Thank you.
Also, we have a question from Dr. Mustafa. Is there any difference in the MRS of stroke patient treated by the mobile stroke unit plus emergency medical of same last non-well time to needle time?
I don't know that the best MSU standardized last known well specifically in MSU versus needle time. I think the effect has to do with time. So in the best MSU patient population, about 30% of the patients were able to be given IV thrombolytic within the golden hour. Different from the regular population of patients. So I think the time saving is what translates into neurological recovery. saving. So I think time is the big difference. We can get to the patient sooner and initiate medication sooner.
Okay. Also, there's a question asked about why there's a fire truck near the mobile stroke unit.
That was my same impression when I started in this, because I was always in the hospital. I don't know anything about what happens outside. In Los Angeles County, all of the EMS providers are fire departments. And so the fire engines go, and all these fire engines, there are firefighters who are also cross-trained as paramedics, in addition to an ambulance, which is also there on scene to transport the patients. So on every medical call in Los Angeles County, there's a fire engine, and sometimes two. So it's very confusing.
Okay. I think that's all. Is there any further question, please? Anyone? Okay, this is a question from Dr. Mashuk. He says he's from Pakistan. We have CPU chest pain unit, a unique model, and excellent results for acute MI in busy metropolitan city. But regarding stroke, it is a good idea. Also good. I think this is a comment.
If you think of these resources, maybe one day we call them golden hour emergency resources. I think it's fantastic that you have the chest pain unit. Maybe this is going to be good for neurotrauma patients, MI, and stroke. And maybe they're modular, and you can configure them to what the call should be.
Okay. Dr. Durham also asked about if the mobile stroke unit is equipped with CT scan in the same truck.
Absolutely. So that's what differentiates a mobile stroke unit than any other ambulance. The equipment on it is a CT scan. It's a head-only CT scan, so because of the gantry is small, you're unable to scan anything below about C1. So you're not going to get a CTA of the neck, but you can get a CTA of the head from C1 and above.
Okay. Dr. Amran have a question, please.
Yes. Excellent talk. I just have a question. What about the results of delayed thrombolysis followed by the thrombectomy? Is any recent evidence of that when we are combining of the two procedures? Would it be beneficial for the patient?
Great question. Thank you very much. With respect to mobile stroke units, the benefit of giving the IV thrombolysis even earlier than before is that actually in a case series we did with Cleveland Clinic and presented at the International Stroke Conference a couple of years ago, we found that in patients with CTA shown LVOs, giving early IV thrombolysis either distalized the clot or completely recanalized the clot before the patient went to the angio suite. So there's certainly an ability to help patients even recanalize prior to the thrombectomy procedures. But I think that the same kind of age-old question, do we go directly to angio or do we give IV thrombolysis? In this case, there's even less and less delay because we're getting to the patients so hyperacutely. So I would advocate to, even though the rates of recanalization are not high, for example, for an ICA occlusion or proximal M1 occlusion because of the clot burden, maybe giving the IV thrombolysis so early gives a patient a chance for that clot to become smaller, distalize, or even dissipate before going to the angio suite.
Thank you so much.
Please, any more questions? If you have a question, raise hand.
One more question.
Yeah,
after
go ahead,
the
please.
yes. What about the experience about dual antiplatelets after the thrombolysis? Would it be continued for more than 3 weeks or the 6 weeks or the 3 months? Is there any definite duration to continue dual antiplatelets after the thrombolysis?
Sorry, I was muted for a second. It really depends on the mechanism by which the stroke is produced. If it's something like atrial fibrillation, a dual antiplatelets would not give greater benefit than anticoagulation. So in patients with any IV atrial fibrillation, hypercoagulable state of malignancy, etc., or DVT or the PFO, those patients I go for anticoagulation. And in patients where it depends on if they came in on a single antiplatelet or not, what's the mechanism? Is it atheroembolic? Is it artery to artery athero? What it is, and how beneficial the aspirin and Plavix would be. So it's a case by case scenario, the medical management, depending on the etiology of disease. I put in the chat my email and my phone number if anyone needs anything, and I'm more than happy to be available, WhatsApp or email or one.
Thank you, Dr. Noor, for this nice lecture. Thank you.
Thank you so much. We appreciate you.
So we will use this time to let Dr. Hussam have a comment. Dr. Hussam Abdel Rasool.
Okay, good evening, everybody. First of all, I would
Good
like to
evening.
thank Dr. May for her amazing lecture. And I am Dr. Hussam Al-Rubayyi, member of the Higher Committee for Stroke, Ministerial Committee for Stroke Treatment in Iraq. I'm here glad to announce that in the next Friday at 5 p.m. in Babylon Hotel, we will have the first Iraqi Summit, first Iraqi Stroke Conference held endorsed under the care of Ministry of Health. So we're sorry for some logistics to delay in announcing the invitation letters, but sooner in the few days we will go to print and distribute the invitation letters. And now we have also just established the National Stroke Iraqi program, which will be directly from the Ministry of Health, and it will direct all the progress and the arrangement of stroke service improvement of care. The National Stroke Iraqi program will work to accumulate all the efforts by every neurologist, intensivist, emergency physicians to work in one avenue to improve our stroke service. So the best is yet to come, and hope for all our colleagues in Iraq to attend our summit in the next Friday in Babylon Hotel at 5 p.m. So we will have our first great meeting, and we'll announce the launch of treatment. And many thanks to Dr. Amin Nour. Today I've added to my group, to our group, Dr. Ali Abdelkarim Sheikhi, who identified her and congratulate our effort and activity in improving the stroke service. Okay, and best regards.
Thanks, Dr. Hussam. And Dr. Ibrahim, you don't have any further question?
No, there is no question. Thank you.
Okay, thank you. I would like to thank Dr. May Nour for her excellent lecture and this sharing this way of saving more life and more early. And also, I would like to thank you all for attending. We remind you to follow us on social media and join our network if you haven't yet. And last and not least, we want to thank Norman's partner for hosting this webinar. Thank you, everyone, and have a good night.
Thank you.
Thank you very much.